Hi, everyone. My name is Jessica Rector, and I am president of the NCSA. And today we're going to do our webinar on understanding COVID-19 and the GLP-1 medications and exposure to pregnancy with Chris Stallman from Mother to Baby. If anybody is on and wants to hang out after Chris is done with their part of the webinar, you're welcome to do that. And I'm going to go ahead and get started by letting Chris introduce themselves.
Awesome. Thank you, Jessica. So as Jessica said, my name is Chris Stallman. I am a teratogen information specialist. So basically, I talk to families, clients, people who are pregnant, who want to get pregnant, breastfeeding, and their healthcare providers and the general public about exposures that can happen before, during, and after pregnancy, in breastfeeding, and in cases of adoption. And these have been some areas of my specialty. I'm super interested in these specific areas. I've done a little bit of research here, and very happy to share because there's a lot of information and misinformation floating around. And healthcare providers of all varieties are wondering, when I see what's out there, how do I know what's real? How do I stick with what's important for my clients? And that's a little bit of what we're going to go over today, including a little bit more about the Mother to Baby organization. Okay, so by the end of this session, participants will be able to identify some of the commonly asked questions about COVID-19 and the GLP-1s in pregnancy and also in the postpartum space. Apply communication strategies that support families and their questions while staying within scope, and then recognizing when you need to refer out and who you might want to refer out to, depending on your preference, on your contacts, and also what may be best for your client. So I'm going to give a really brief overview of the Mother to Baby Otis service. We're going to go through case review and discussion. So I'm going to show you how we at a TIS would approach one of these. And then we're going to go through the questions that you might receive as a newborn care specialist, along with some strategies on how to answer them and stay in scope. So we are an exposure information service. So Mother to Baby has been around for decades at this point, born out of a lack of information about exposures in pregnancy back in the 1970s. What we do is we take the evidence, so we go and find all the current research, the articles, new stuff that's coming out. We critically evaluate the literature, determine, is this a risk that we're concerned about? Is this something where there might have been a flaw in the data? And then we distill that information. So folks, again, who are looking for it, providers are usually looking for a very quick summary of the information. Everybody's quite busy. We find that with providers across the board, and patients kind of go in between. Some want a lot of information, a little bit of information. We specialize and we can give most people what they're looking for. We are 100% no cost. We are free. You do not need to even create a username and a password to get into our website. We will converse, email, text, or chat with anybody who wants to talk about it. And we have services available in English and Spanish. So we have been listed by agencies that include HRSA, that is one of our main funders, the Centers for Disease Control and Prevention, and the FDA, including the Office of Women's Health. Last year, more than 100,000 people, that does include the general public and healthcare providers, sought information about birth defects prevention and exposure information from Otis and Mother to Baby. We cover the entire United States. We don't have affiliates in every state, but collectively we do the whole job. So I'm in Arizona, for example. I cover Arizona, North Dakota, South Dakota, Kansas, Colorado, and New Mexico as well. And we will cover everybody in the United States. That is currently the limitations to our funding, but that also does include the territories. So Puerto Rico, Virgin Islands, and so forth. We also have an arm of pregnancy studies. So very often we get very, very nice people who say, okay, well, you don't have any information for me in my pregnancy, but I'm currently pregnant and taking this medication, or I'm breastfeeding and taking this medication. Can I give back to the data? That's where our pregnancy and breastfeeding studies come in. So this is something, again, easily available on our website. Don't want to belabor the point, but if there is someone who is interested in giving back to pregnancy studies information, we have a no cost and low to moderate commitment way to do that. We don't ask anyone to take medications. These are purely observational studies. Some of the other resources we have to offer are our fact sheets, over 300 in English and Spanish, written at about an 8th grade level, trying to get down to that 6th grade, but it's super hard. But again, completely free, don't need to log in, available, easy for patients and providers to read, download, and share. We have a baby blog, and we also have a podcast. So just kind of finishing up with the mother to baby realm. We also work with LactMed. We'll talk a little bit more about them later, but we do have an app completely 100% free. So in your, however you get your apps, check out LactRx. This is information about exposures in breastfeeding. It's run by Phil Anderson out of UC San Diego, and it's updated every week. This is an incredible resource, free to providers. And here is our contact information. I'm going to leave this on for just a sec. Take a screenshot or a snap, or again, just come to our website and we are happy to answer any questions that anybody has. And believe me, we have very likely heard it before. So nothing is off limits. Confidential, anonymous information and counseling.
Better. Jessica messaged me like her webinars on.
So, as you may, we at Mother2Baby get a lot of questions about common exposures, right? Things like vaccines, maternal medical conditions, infections, medications, of course, dad's exposures or any paternal exposures, any substances, so things like alcohol, cigarettes, tobacco, THC, all of those. Two of the biggest ones we get last year, our number one topic of inquiry was herbal products, supplements, protein shakes, stuff like that. There is not a lot of regulation, not a lot of information, and a lot of questions because the wellness industry is so big. That's just a little taste of what we handle. Again, though, we will answer anything that we can. And here is really the crux of Mother2Baby, and not just Mother2Baby, right? We know that this is what healthcare providers are doing at every single level, whether you're in a clinic or assisting a family, a client in another way. We're all looking to find and share evidence-based, reliable information so patients and providers and clients and the public can make informed decisions about their exposures. We like to help folks understand the risks versus the benefits, with the risks being untreated illness, not necessarily risk from medication. Sometimes there is, and we're happy to discuss that, but a lot of times the risk is what happens if you are not treated while this condition is occurring, right? Is that going to be a worse outcome? Sometimes people will just sort of stop taking their medications cold turkey without talking with their provider. We do not encourage that. We want folks to, again, make those decisions that is best for them and their health. And that does include with breastfeeding. Sometimes people will say, well, I can't breastfeed now that I'm taking this. We can help navigate through that information. And sometimes we're able to alleviate anxiety and help increase that peace of mind. Because again, you know, folks out here in the pregnancy and lactating space, by and large, are doing the very, very best that they can. And so we want to do the very best that we can to support them wherever they are. Okay, so we're going to run through two very related cases and show you how a TIS like Mother2Baby Arizona, for example, would approach a case. So in keeping with today's topics, we're going to talk about Sarah. She is 36 years old. She was diagnosed 2 years ago with type 2 diabetes and is classified as overweight based on her BMI. She is currently taking two medications. So she's taking Ozempic, which is the brand name of semaglutide, 2 milligrams weekly, and she is taking metformin, 1,000 milligrams BID. No previous pregnancy, no known complications from diabetes, which is important here. She started Ozempic about 6 months ago for glycemic control and weight loss. She's got a good A1C right now at 6.5, and she's lost a little bit of weight, which she feels good about. However, this morning she came up positive on a pregnancy test. And so if you were meeting someone at this space, if they were here, I want to show you how we would counsel and the information that we would provide. Okay, so here are the important points to us. She's 36 years old, approximately 8 weeks pregnant with confirmation on ultrasound. The reason we look for that is because there can be different parts of the pregnancy when we're concerned about different risks. So if we have a sense of the dating of the pregnancy, it helps us in our assessment. Now, not everyone is confirmed by ultrasound on 8 weeks. I know actually that's a little bit on the more rare side. So let's say that it was, 8 weeks unconfirmed in the first trimester, we would still proceed in the same way. Second or third trimester, our counseling might be a little bit different. Patient is overweight with a 2-year history of type 2 diabetes, so we know she has an ongoing medical condition. No previous pregnancy, so we don't know how the body might react being pregnant and having type 2 diabetes, but also currently has no like eye or kidney or pancreas or other known complications because of the diabetes. So that's definitely good. Is on Ozempic right now and has been on for about 6 months and still on that metformin. It was for glycemic control and weight loss. That comes up later. And she has a good A1C. So before we go any further, typically this patient seems to be doing well. So naturally, there is going to be more thought about stopping medications when we know that a person is doing so well with their medications currently. Now we have to incorporate, all right, well, what about the pregnancy? Okay. The very first question that people typically ask clients and providers alike is, should Ozempic be stopped immediately? We have gotten this so much, especially when these drugs were first more highly marketed. Now, I mean, there are absolutely ads everywhere. People say, if I find out I'm pregnant, should I immediately stop? We at MotherToBaby are never going to encourage that, right? Because we are not prescribers and we are not this person's individual provider. So we're not going to tell people to start, stop, or change their medication, right? So if a client asked me, I'd say, we do not recommend you start, stop, or change your medications without talking to either the healthcare provider who prescribed them for you or the provider taking care of your pregnancy. Either way, they should know what you're taking, how often you're taking it, and then they will guide you forward, right? We never want someone to stop. And especially a medication like this, where we don't know what stopping will do to their glucose control, their symptoms, any possible weight gain, this needs to be a conversation with the provider. Okay. What are the risks if someone decided to continue Ozempic during pregnancy? Can tell you straight up that the data is really, really limited, in part because people are not routinely giving this medication during pregnancy. So, of course, we have no data, right? Because people who are pregnant or could be pregnant, meaning they have the biological capacity and they're not on either long-term or permanent birth control, are routinely either excluded or removed from trials, right? So we really don't have any data. What we get sometimes is this almost accidental data, meaning someone got pregnant not knowing that they were going to get pregnant and they had some exposure to this medication. There is one publication that suggests the use of GLP-1s in general is not expected to increase the chance of birth defects. And that is good news, but that is one study, so the data still remains very limited. Okay. What is known about the effects of Ozempic on fetal development? Again, not very much, right? We had that one study that showed no increased risk of miscarriage or birth defects, but there are some other considerations, right? Typically in pregnancy, most providers, if not all providers, don't want the person who is pregnant to lose weight. We know that there are outcomes tied to weight loss during pregnancy, either intentional or unintentional, and they like to keep a good eye on that. We also know that there is an increased risk to fetal development if diabetes, specifically glucose control, is not well controlled in pregnancy. We know that there can be birth defects. There can be complications down the road. So like increased blood pressure, increased needs for C-section, early delivery, issues with the baby getting too big depending on the glucose control. So we don't know a lot about the effects of Ozempic on fetal development, but we do know a lot about the risks of diabetes or rather high glucose levels in a pregnancy. So here comes that risk-benefit analysis. We're not sure what the medicine could do, but we do know what diabetes will do, and we have to make a choice from here. What is the risk of stopping Ozempic and the management of glycemic control? Now, There are lots of medicines that can aid with glycemic control during pregnancy. I definitely want to recognize that. And that might be what is best for this patient. It is not for us to decide what's best, it's for us to present this information. So, if they're going to discontinue Ozempic, which many people have done, there does need to be optimal management of that glycemic control. So, if it's another medication, more strict diet and lifestyle interventions, if they want to go to insulin, whatever the case may be, that's fine, as long as we are protecting the health of the person who is pregnant alongside protecting the fetus, which is what we all want to do. We want to protect everybody involved. If optimal glucose control cannot be achieved and maintained, again, there are increased risk of birth defects, specifically when that loss of control is in the first trimester, miscarriage as well, but also later on, we have the fetal macrosomia, so baby's much bigger than what we would expect, that increased risk of high blood pressure, which can lead to preeclampsia, which can lead to eclampsia, which can lead to seizures and death. So we want to keep a really good eye on that. And then things like preterm delivery and stillbirth. So the point is, we want to control that glucose and keep it in control for as long as possible for the most optimal outcomes. Does that include Ozempic? The short answer is it might, but we do have other medications, and there's not a lot of specific guidance around the use of these medications in pregnancy. Okay, so let's say she stops Ozempic. Baby's fine, pregnancy's progressing well, glucose is in control, she's doing great. Now she wants to know, okay, well, I stopped in pregnancy, that seemed okay, but I'd like to start again right after the baby is born. Can I do that? Can I use Ozempic while breastfeeding? Okay. So this is an interesting question. So I'm going to do my best to answer it because I'm going to give you a little bit more detail later on. So when you sub-Q, right? So when you have the injectable form of semaglutide, when they tested breast milk samples of people who were taking the max dose up to 2 milligrams one time a week, they didn't find any of the medication in breast milk, which is good. That means low transfer. In infants who were breastfed while mom or breastfeeder was taking Ozempic, no side effects were reported. Now, it's very hard to prove a negative, right? Just because there's no side effects doesn't mean that there never will be. But what this is preliminary information that is somewhat reassuring. It is suggested that only the injectable forms of semaglutide be used in breastfeeding. You might have heard about the pill, which I think is Ribulus. It has an extra ingredient in the pill form that we don't want building up in a breastfeeding child's body. I'm going to give you a little bit more about that later on. But because of that extra ingredient in the pill, they're saying if you're going to use it in breastfeeding, the injectables are the ones that we feel most comfortable with. So when you see this, it may seem, okay, well, it may be possible for people to breastfeed while using Ozempic. And it is actually possible, but it's still recommended to avoid breastfeeding. I'm going to get to that later on, but I did want to leave you with that, right? So sometimes the information that is available to us and the conclusions that we can draw from that still do not match either manufacturer's recommendation or, high level guidance from like ACOG or ABM or something like that. So I also wanted to address that with many things, there are this conflicting evidence and these conflicting ideas and how to navigate them. Okay. We have a second case. So this is Jessica, 24 weeks pregnant, so well into the second trimester with her first child, mild asthma, but she hasn't been hospitalized. She's otherwise healthy. And her OB wants her to receive the COVID-19 vaccine because she has asthma and because she's pregnant. Jessica, however, has concerns. She has some questions about the safety of vaccines and how it could affect the baby's development. So again, what's important here? She's 28 years old, 24 weeks pregnant, G1P0. Okay. So we don't know if she's at higher risk because of her personal history in pregnancy, because she's never had a pregnancy before, but the asthma is a red flag, and pregnancy is too. So there is a little bit of immune compromise when someone's pregnant, could be at higher risk to not just get sick, but get more sick over time. Patient has some hesitancy, so there can be some friction later on. It's okay to know that going in and remember that you may need to diffuse, especially if there's a lot of fear or strong emotions around that. She's worried about the safety of vaccines during pregnancy and how it could possibly affect a fetus. This is not an uncommon question that we get. It's like, okay, I don't care about me. Like, I'll be okay, but will it do something to the fetus? And of course, we need them both to be healthy if we can. Okay. So some of the questions we get, because we do say, yep, so based on the recommendations on the data we have, that there is no reason, unless you are allergic to any component of the vaccine, necessarily to avoid the vaccines either during pregnancy or during breastfeeding. And that's great for us to say, but people say, well, this is new. What data do you have? So what data is out there that says that we can do this while we're pregnant and breastfeeding? So, COVID-19 vaccine studies include hundreds of thousands of people from all over the world. So, we actually do have some really good data right now, which is great because when the vaccine was first being put together, when we were going through the emergency use authorization, of course, there's a lot less known, but we have a lot of solid data now, which is very, very helpful. Vaccine use in pregnancy has not been associated with increased risks to the pregnancy. Again, this is a few thousand pregnancies. So what we say increased risk, what we mean is we have not seen an increased risk of birth defects, miscarriage, preterm delivery, baby being small for gestational age, high blood pressure in the mom, early delivery, or stillbirth. So that's definitely good news. Studies show that the COVID-19 vaccines are compatible with breastfeeding. In moms and babies, no serious reactions have been reported. And the reason that these are underlined is because these contain the direct link to the studies that I'm quoting. So I'm happy to send the presentation over or send the links over so you can see all the sources that we're using because there is a lot of good data out there right about now. Okay, so we see the data. We see that it's okay for most people. How do the vaccines help protect mom and baby? Why is it worth it for me to get this vaccine if it's worth it at all? Well, antibodies. We do have good data that show that vaccination during pregnancy and breastfeeding does build antibodies, which of course help the person who received the vaccine. So in this case, the person who is breastfeeding or the person who is pregnant. And you can transfer those antibodies. A lot less is known about the antibody transfer and how much occurs during pregnancy. But we do know that it does occur during pregnancy and it can also occur during breastfeeding. So the antibodies make it into the milk, baby drinks the milk, gets a little bit of a boost. And what are the risks of COVID-19 infection? So again, this is that risk benefit summary, which is again, not the risk of the vaccine, but the risk of getting COVID, the risk of not getting the vaccine and being in a position where you could contract COVID-19 during pregnancy. So what is that risk versus any potential risk, which now for us with vaccines is the risk of the unknown, right? In pregnancy or breastfeeding. There is sufficient data to show that COVID-19 during pregnancy does increase the risk to pregnancies. And a lot of that is because maternal health is compromised, right? Like the person who is pregnant or breastfeeding is very busy trying to fight off that COVID-19 infection. And so their body is not working optimally. It can increase the risk of preterm delivery. We've seen that in a lot of data since the beginning. We're not 100% sure why it's happening, but it is a known outcome. Again, that high blood pressure, blood clotting, which you definitely don't want too much or too little clotting during a pregnancy, the need for C-section, infection in the placenta, so placentitis, and then stillbirth. So those are the complications associated with COVID-19 during pregnancy. And there are different outcomes for people who are vaccinated versus people who are not. People who are vaccinated either before or during pregnancy tend to do better than folks who were not vaccinated at all. Most babies who have been hospitalized with COVID-19 infection were born to women who were not vaccinated during pregnancy. And we do know that there are some more severe outcomes when you get COVID that early on in life. And that is something we would like to avoid if we can. In general, the benefits of vaccination outweigh the risks of untreated illness. Most vaccines are considered compatible with pregnancy. I think the only one that is a 100% no-no for everybody is yellow fever. I think that's the only one. Everything else is either it's okay to go or case by case basis. So, for example, MMR being a live vaccine, typically not going to be given in pregnancy. However, if someone is at a very high risk of getting measles or mumps or rubella during pregnancy, that may change. So, we have some general rules, but again, case by case basis. Okay, so as newborn care specialists, you absolutely have important work and a place in this whole situation. Um, Newborn sleeping patterns, support for infant feeding, soothing, newborn behavior and development. I certainly don't need to tell you the scope of your job, but what I wanted to show you is that when we get to the next set of slides, I understand that you and I are not in the same position, right? It is my job to directly give this counseling and information versus a more general support role. So is there a way that we can combine what I do, what you do, in order to give the best outcomes to your clients? Right? Because we realize that you are not in a position, as I am not either, to diagnose medical conditions, interpret medical test results. We at MotherToBaby also don't provide recommendations, simply information, or evaluate medication safety during pregnancy or breastfeeding. That's closer to our wheelhouse, but not necessarily yours. To my understanding, and again, if I have any of this incorrect, please feel free. But in my understanding, the role of a newborn care specialist is to educate, observe, and help with the referral process. Really, you're a beacon of support for these clients. So when you have someone in your role who is primarily there for support and education, and you have all of these questions and people almost going thirsty in a sea of information, right? There's so much information and misinformation out there. It's almost like could die of thirst just looking for the right thing to drink. And so when you have all of these questions here, can I breastfeed if I have COVID? Can I take a GLP-1 while breastfeeding? If you're getting that question, what is a way that you would be able to give some information, but also stay in the scope of what you are there to do as a newborn care specialist? So we're going to walk through each one of these questions one at a time. Okay, how do you answer these questions and stay in scope? Can I breastfeed if I have COVID? So this is one that we get all the time, and my guess is you may too. So here's the information piece. There are multiple studies that suggest COVID-19 does not pass through breast milk and does not infect the baby. So that's a point of reassurance, right? It's like, okay, well, we don't expect that even if it does get into the milk, that it's not going to be an infectious agent through the milk. And so the information available along with the guidelines from folks like ACOG, for example, say, sure, if you want to continue breastfeeding, absolutely, go ahead and do that. Now, is that your call necessarily to make? No. But you're armed with the information, you have that in your head. What can you do? Okay. You can certainly let them know, hey, there are groups that have ideas on this. This is something to talk about with your baby's pediatrician, right? But you have the source in case you need it. Other things that you can remind them of, okay, so if you're sick and you're going to go ahead and breastfeed your baby, good for you. That's awesome. Thank you for feeding your baby appropriately. And also, you want to avoid transferring COVID to baby. So you as an NCS, you are supporting their good hygiene as well as your own. So hand washing, wearing a mask, not coughing directly on the baby, especially while you're feeding. If you're not feeling well enough, right, you can absolutely express the milk and have someone else feed the baby if that's how you want to reduce your contamination, whatever works best for the family. And also encourage them to check, either with their provider or with their baby's pediatrician in case they're concerned. We do not expect side effects if someone is pregnant or nursing and then gets COVID-19 vaccine, but anything unusual with the baby, especially when there's a viral illness going around a household or a center, definitely keep that pediatrician in the loop. And of course, I hear this all the time. Some people say bottle, breast. Just so you know, for us at MotherToBaby, however a person wants to feed their baby is completely and fully supported. We get a lot of, do I have to breastfeed my baby while I have COVID? I feel very exhausted. I don't want to cough on the baby. We are not going to tell them what to do one way or the other. We're going to get at how they want to approach this and what information and support services we can give. Okay. Sometimes people say, okay, well, I got the vaccine now that I am postpartum. How long do I have to wait to breastfeed if I just got the vaccine today? We get this very, very often. And there is guidance from ACOG and the Academy of Breastfeeding Medicine that says there is no waiting period. It's as soon as you're ready to go. Now, with that being said, sometimes folks get a vaccine and then they have some side effects, right? They're feeling tired, they have a fever, something like that. Other considerations may arise. But we have nothing, there is no evidence, there is no benefit to stopping longer than a person needs to recover from the shot. So if they got shot in the right arm, that's the primary arm they hold the baby, they may need to make some adjustments, but it's not because of the vaccine in the breast milk. And so for the newborn care specialists, other ways that you can help here is, encourage them to stay hydrated and to eat well. And again, that's for their own health, their own well-being, and their milk supply. Plan for fatigue. It's like, I've had 3 vaccines before and they all wipe me out. I'm just not able to do much in the first couple of hours beforehand. If that happens to be the situation, can plan around that. Continue typical feeding for, parent and baby, and then watch baby cues, meaning, there may be something else. But again, we are not expecting side effects here. It just may be, they're a little bit more attached and mom is a little bit less so because she's trying to rest, or, that arm is still sore, that type of stuff. Does my baby get antibodies if I get a COVID vaccine during pregnancy? So again, here the data is really limited, right? We know that it's helpful. It's not clear the extent to which it helps, but we do know that antibodies are passed down. And there are some great studies that came from the ACOG group and, again, the Academy of Breastfeeding Medicine. And then some extra bonus, it's like, well, okay, even if you're getting it during this postpartum period and you happen to breastfeed at the same time, let's say that you did get it, and so there's not as many antibodies as if you would have gotten the shot in the breastfeeding period. Breast milk is still incredible. It provides comfort, nutrition, support, and possible immune support for the baby, even if you didn't get the vaccine in the recent past, right? Other antibodies are in breast milk, one of the things that makes it so nutritionally sound and healthy for baby. Can the vaccine itself affect breast milk? We get this a lot too. Like, okay, I'm not really worried about the vaccine, but is it going to lower my milk supply? Is it going to change things? What do I have to do? Is there something I can do? There are some women who reported a temporary drop in milk supply after their second dose of the 2 forms of the COVID-19 vaccine currently available in the US. So we saw it happen less often with Pfizer than with Moderna, but for all of the cases, and I believe there was less than 1 dozen reported, milk supply returned to normal within 3 days, so 72 hours. I do realize, especially in the early period, any drop in milk supply can induce panic, right? Because they're already trying to build up and establish or maintain that breastfeeding relationship and the milk supply, and people are very wary, as absolutely makes sense, if there's a chance that their supply could be lower. So the rules that come with any reduction in milk supply or perceived reduction in milk supply are also very helpful here. So encouraging that frequent feeding or pumping to help keep that milk supply intact and up a little if need be. Supporting that rest and recovery. Again, some people have bodily reactions to the vaccine. So are they doing their regular stuff? This hasn't changed, that their body still needs rest, nutrition, and hydration. Watching babies' feeding cues, again, in case there is a drop in milk supply. So maybe baby is a little bit more hungry or trying to get to the breast or the bottle more often because there's been a drop in the supply. And then, of course, always offering the reassurance that, if it does seem like there is one, you're still doing all the right things. This is going to be a temporary thing, most likely. We're going to try and support you through this and keep that milk supply steady. Do babies need the COVID vaccine? This comes up typically when folks get it during pregnancy. And There have been some changes to this guidance. So, with all of these guides, especially around these two topics where there's a lot of information coming out and a lot of things changing, some of these recommendations have changed over time. From the American Academy of Pediatrics, this is their statement, and everyone may say something a little bit differently, but mostly they're in agreement. Infants and children from 6 to 23 months have a higher risk of getting really sick from COVID. So, what we would all like to do collectively is avoid that as much as we can. AAP recommends that all kids in this age group who do not have contraindications, meaning they're not allergic to ingredients in the mRNA vaccine, that they receive the COVID-19 vaccine. And again, this is one of those pieces where there has been a lot of talk, a lot of changes, a lot of realignment with larger agencies and some politics tinged in here. So, what I would really suggest for stuff like this is to stick to the guidance that you can find from a reputable source. Check it often to make sure it hasn't changed. And again, this is going to be a pushback to the provider. It's like, well, I can't tell you if your baby needs the COVID-19 vaccine, but it is recommended for kids in this age group. This is a conversation for your pediatrician. This is one where, again, you can provide that information, but erring on the vague side, I would say, because in case, someone has other ties to this type of information, we don't want to alienate anybody. Encourage those vaccination conversations between parents and the pediatrician. Monitor for symptoms such as fever. So let's say that baby does get the vaccine. They can have reactions to vaccines just like everybody else. And at 6 months or even a little bit more than that, they probably haven't had a ton. So just keep an eye for things like fever, cough, of course, trouble with eating or breathing, being very sleepy, and just let the parents know if there's anything unusual with the baby. Side effects are rare, but that doesn't mean that they're impossible. So this is a proactive piece. It's like, okay, baby got it. We're just going to watch baby for symptoms. Good hygiene, as always, supporting healthy routines. So even if sleep is interrupted or baby slept extra long because they got the vaccine, trying keeping those routines going. Same thing with feeding, hydration, that overall support of, keeping everything moving. And then again, your best friend is staying updated with the current guidance. Even if you may not be dispensing it directly, it's good for you to know where the public discourse is turning and what they may or may not be hearing from their healthcare providers. Can I take a GLP-1 by breastfeeding? So this is going to tack back to our original case number 2 with Jessica. So we talked about this, that there is a lack of data on GLP-1 use in breastfeeding. So semaglutide, which is Ozempic, Wegovy, and Resiblis, I believe, was not found in breast milk of moms who took it as an injection. Some oral forms of semaglutide, so the pill, contained salcaprosate sodium. And the issue with this is we don't want this building up in the body systems of an infant, right? This is not something that is in the injectable forms, but this other ingredient has a long half-life, and we don't want infants exposed to that. So that's why you may see that if a GLP-1 is recommended during breastfeeding, it's the injectable kind and not the oral kind, because the oral kind have this extra ingredient. It's similar with tirzepatide, so that is Mounjaro or Zepbound. Again, usually not found in breast milk when mothers take the injection, up to 5 milligrams. So very little, if any, passage. Now, I want to remind you that the max dose for Zepbound or Mounjaro is 15, and here we have data up to 5. So it doesn't mean that someone taking more than 5 can't breastfeed. It means we don't have that data. That data does not exist, right? Even if it did get in, though, the amount would break down in the baby's stomach, in their gastrointestinal system. And so typically, if a woman needs tirzepatide while breastfeeding, we have no reason to stop her. We do not have compelling evidence that this would cause anorexia in a breastfeeding newborn, have other types of side effects. But again, a lot of that is a lack of data, right? So when you see that, it doesn't appear to get into breast milk and we haven't had side effects reported, but you're also seeing people recommend not to use this in breastfeeding, it's very much like, well, why, right? Like, Is it simply the lack of data? And the answer is yes, it is the lack of data. Because we don't want anything negative to happen, very often folks will go to the abundance of caution. It even says, GLP-1 should be used with caution, especially when breastfeeding a newborn or a premature baby. And again, that is not because of things we've seen, but it is due to the lack of data. Okay, so encouraging that communication with the provider before either starting or continuing a GLP-1. And if someone does take a GLP-1 by breastfeeding, watching the feeding patterns of the baby to ensure that baby is eating as typical, gaining weight, meeting developmental milestones. And if there's any changes in baby's behavior, so like being really sleepy or like vomiting that is more than the typical spit up, or any type of feeding changes, baby wants more food, baby wants less food, talk with the parents about that. And then the other piece of it is people who are taking GLP-1s may have less milk supply, in part due to nutritional deficiencies and dehydration. So supporting that parent who wants to continue to provide milk, making sure that their body is in the optimal place to do that. We also get commonly asked if GLP-1s pass into breast milk. I wanted to add this question, not just because it comes up often, but because it also has a key concept that I'm not sure everyone is aware of. So I just wanted to reshare or reiterate this point. Many, many medications and other exposures pass into breast milk. That alone does not indicate a problem. It's the same thing like crossing the placenta. You hear people say all the time, such and such crosses the placenta. That alone is not always a problem, right? So just because it crosses doesn't mean it's an issue. We need to know if when it crosses, does it create another issue? Ozempic was not found in the breast milk of mothers who took it as an injection. I know we talked about that already. We also talked about the extra ingredient in the oral semaglutide, right? So we don't know much about the oral form and if it passes into breast milk because we don't want people to use that while breastfeeding. That's number one. Tirzepatide is not usually found in breast milk up to that 5 milligrams. Again, we have no data at the above doses, so the 7.5, 10, or 15. Even if tiny amounts were present, the baby's unlikely to absorb much. So here's the bottom line. It can pass into breast milk depending on dose and which GLP-1 is taken. And that by itself may not be a problem. So again, it's the same idea, making sure they're talking with the provider, making sure that the baby is eating well, any changes in the behavior, supporting that milk supply and the person taking the GLP-1, and then being able to share your resources, right? It's like, okay, where does all this come from? How does my doctor know where to find this type of information? Know your sources, like LactMed. I'm going to show you a little bit more about that. Us at MotherToBaby, and of course, your lactation consultants, who are absolutely invaluable. When can I start a GLP-1 after giving birth? This is one of the more commonly asked questions, and one that is unfortunately incredibly difficult to answer for most of us because there is no official guidance here. You will see people say things as if this is an understood, but it's not. There is no consensus across the board. It's going to depend on the overall parental health. So are they in a position to start losing weight? Are they on a form of birth control? Are they breastfeeding and continue considering getting pregnant later on? How are they doing health-wise? All of these things together. So, due to a lack of data, most experts recommend avoiding GLP-1 medications while breastfeeding. Yes, that is in contrast to all of the things we've just discussed about the low presence in milk and the lack of side effects being reported. It is all due to a lack of data. So out of that abundance of caution, most providers are going to follow this recommendation. Again, that does not exist from like ACOG or SMFM, right? So collectively, folks have decided that this is not a great idea because there's not a lot of data, but there is no guideline that I can specifically point you to that says it. Some providers say 6 to 12 weeks postpartum if they are not breastfeeding. Again, that is not an official recommendation. It is what some folks have come up with. And so you may see that out in the wild. The bottom line is that this is always a shared decision with the healthcare provider and the client. And if they decide to go forward with it again, as a newborn care specialist, you can encourage that communication, support the feeding goals. So let's say that someone says, yes, I very much want to take a GLP-1, but they won't prescribe it to me unless I'm not breastfeeding. How can I get support going the not breastfeeding route so I can get the GLP-1? So there may be some changes there. If someone is taking it and breastfeeding, which technically could happen, watch the baby for changes. And then again, supporting that recovery, sleep, nutrition, hydration, keeping up that breastfeeding if that's what they want to do. Do GLP-1 medications affect milk supply? Well, as far as we know, not directly, right? We don't think that the medication, either the semaglutide or the tirzepatide, that they themselves directly lower milk production. But where you get some of those secondary effects is that people who take GLP-1s, pregnant, breastfeeding, or not, so this is for everybody in the general population, they are more likely to become nutrient deficient, right? Because they are now restricting calories. And that's because they're eating less overall. Even if they're doing it absolutely to the letter, there's a possibility that they could have nutrient deficiencies. They could also have a lower milk supply because of that, right? Because they're not getting the nutrients they need to make the supply that they could typically otherwise. The other thing is taking a GLP-1 may make a person dehydrated. That alone will impact that milk production as well. So it can affect milk supply, but perhaps not for the reasons we had assumed. So if someone is going to take the GLP-1 and they are concerned about their milk supply, a lot of those same principles come back in, right? So drinking fluids regularly, making sure that you're eating as much as you can. And it's funny because before we started the webinar, Jessica and I were talking about the possibility of a lack of nutritional guidance and counseling while you're getting your GLP-1, even more important in the pregnancy space, even more important in the postpartum and breastfeeding space, not just for the milk supply and for the baby, but also for the person who is recovering, who's just been through an incredibly traumatic to the body at least event. So they still need to get well and heal. Watch for those signs of low milk supply as decreased diaper output, baby's hungrier or reaching for breast or mom more often, or the baby's not gaining weight. And then monitoring the patient well-being. If they are going to take the GLP-1, this medication is known to make people tired, to make them feel dizzy. They can feel overly fatigued or weak. They may have dehydration or low calorie intake. Sometimes there's a breaking in period, if you will, where folks are trying to get adjusted and can have some of these side effects. We know that if someone's dizzy, holding the baby during feeding might not be the best option. They may want to pump at least until they feel stable enough, or they want to lay down while feeding to have that stability. So again, these other little things that really have nothing to do with the nutritional quality or any type of risk due to the exposure of the medication, but other side effects that may affect mom, baby, or the pair of them. Should I stop taking these meds before trying to conceive? This is something else that we get asked a lot. And I would say this is one of the places where there is a true consensus, and it's written into guidance as well. So basically, the answer usually is going to be yes. ACOG recommends that all patients use contraception to prevent unintended pregnancy while taking GLP-1s. And again, that's due to a lack of data. And then aside from ACOG, it's very infrequent that many groups will put these types of recommendations into writing, but I can tell you that sometimes providers will also look at the label to see if there's a manufacturer recommendation or suggestion based on either what they've seen or, what their general recommendation would have been. So if you look at the labels for semaglutide, that does include the injectables and the oral form. They all say to discontinue at least 2 months before a planned pregnancy, which is very funny. Just keep that in mind. And then tirzepatide, which is the Mounjaro and the Zepbound, they suggest that you use non-oral contraceptive or add a barrier method of contraception for 4 weeks after you start and for 4 weeks after each dose increase. And again, the idea is they don't want you necessarily getting pregnant on this medication. The 2 months before a planned pregnancy seems like it would work fairly well for folks who were informed about that and for those who are planning pregnancy. So, still in the United States, about 50% of pregnancies are considered unplanned. So, it definitely helps that there is this recommendation, but we get caught up when we're thinking about, doing something before a planned pregnancy. If it's not planned, then what happens, right? They're still going to want you to discontinue. But again, if you're discontinuing this in pregnancy and there's great, A1C and glucose control, you're going to have to think about that. That's a risk benefit. So my point to the newborn care specialist is that this is not always a cut and dry decision. It's going to be recommended to come off of this before trying to conceive, but the actual doing of that is a little bit different than what we would expect. So let's say that these are conversations happening with the clients that you're serving. Be aware of postpartum family planning because some folks don't realize that GLP-1s can increase fertility. That's why the tirzepatide has the add a barrier method, right? Because hormonal birth control can be compromised with some GLP-1s, and not all providers know that either. Again, have them talk with their provider about it and do your best, as I'm sure you always do, right? Because it is hard out there with the internet. Support informed decisions instead of TikTok trends, right? Like GLP-1s are everywhere, especially now. And folks are saying, yep, my doctor started me 2 weeks postpartum. All of that is awesome if that's their thing, but it's not a one size fits all, right? So it's always going to have to be the sum of their experience with what is recommended. Here are some selected resources, so absolutely not exhaustive, and my guess is you all have or have seen most or all of these perhaps, but definitely some good places to go. Of ones that I didn't mention in the presentation itself, the Food and Drug Administration has a label search if you want to know what a current label says. And again, that is not always the optimal, but it is nice to know what the label says because then we know where people are getting some of that information. And of course, we have Mother2Baby. Specific to this, Mother2Baby has fact sheets on the Mounjaro Zepbound, the Ozempic, and the other forms, type 2 diabetes, metformin, gestational diabetes, obesity, and exercise. So we do have one specific to here. So if you were ever looking to get that information, these are a question and answer format. So it tells you what the medication is, how long it can stay in the body, does it increase the chance of birth defects, miscarriage, pregnancy complications, learning in the child if they're exposed to it in utero, like does it increase the chance of things like, behavior or learning issues? What happens if a male partner or a sperm donor is taking this medication, and what it would look like in breastfeeding. So again, 100% free and all laid out and ready for patients and providers to look at. We've also done this a couple times on the podcast, so I'm actually the host for the Mother2Baby podcast. And we've had a couple of episodes again because these are such hot topics over time. So again, free for you guys to take a look at. And as I start to wrap up the presentation, as you already know, exposures, all kinds of exposures in pregnancy and breastfeeding are common. Information is usually limited or hard to find, confusing or conflicting, but that evidence-based information, especially in today's climate, is more important than ever before. That risk benefit is crucial to help maintain client autonomy and decision making. And of course, you and newborn care specialists everywhere and your organization are so important. Thank you for taking care of clients in need. Again, there's sometimes a lot of conflicting information out there, and folks who are there for the benefit of parents and families and women and everybody part of these processes is just absolutely crucial. So thank you. This is the end of it. These are my 4 kids. And I always put them at the end of a presentation because it's pretty hard for me to be nervous knowing that they're waiting at the end. So thank you for allowing me to come and share today. And I'm happy to answer any question that I can.
Awesome, thank you. And I know we have some questions in the chat. Lauren, can you verbally ask your question just because I think I know what section it was from, but I don't want to ask it wrong, if you can hear me. If not, I could just ask it. Were they not vaccinated during pregnancy or not vaccinated at all? I'm assuming she's talking about the COVID.
Okay. So people who are not vaccinated during pregnancy and have not been vaccinated at all, so before or after pregnancy, we would expect that those folks have the worst outcomes. People who were vaccinated before pregnancy but not during pregnancy had better outcomes than people who were not vaccinated at all. However, people who were pregnant and vaccinated during pregnancy still had worse outcomes than people who were not pregnant. So, in general, we want someone who is vaccinated. If they're vaccinated in pregnancy, that may suggest better outcomes than being vaccinated before pregnancy, but we don't know enough about antibody transfer. We know that people who were not vaccinated at all and were pregnant had worse outcomes than people who were either vaccinated before or during pregnancy versus those who were not vaccinated at all. I hope that was clear because I know that that is very complex.
And my question was when you're talking about vaccines, does that also include so like we get vaccinated sometimes when we go to different countries. Like I had to get vaccinations for Egypt. Were those included in the vaccinations you were talking about, or just like the main ones we know of?
No, mostly all of them on the big, and I believe it's the CDC that has a list of vaccines that are required per country. I think that nearly all of them are okay in breastfeeding, except for yellow fever. And I know that there's a couple more that are contraindicated in pregnancy, meaning they don't want you to get them at all. But the point I wanted to make about MMR is that even though that is a live virus that is weakened and usually not recommended in pregnancy, if the risk is really high where you're going, it's very similar with smallpox. Typically, they don't want to give you smallpox in pregnancy, but if your risk of contracting is very high, they're going to offer that to you because they want to protect the pregnancy. So it's an extreme risk benefit analysis. The only one I know for sure that they don't want in pregnancy or breastfeeding at all is that yellow fever. So the rest of them end up being risk benefit.
Okay. And when, so I know a lot of times, I mean, before the webinar started, we were talking about how like just how popular the GLP-1 has become. Does the same information, I mean, because you were talking about the different places that compound it and how they're getting in trouble for that.
Yeah.
I know a lot of my clients, they purchase theirs directly. Is is it made different or is that different than like getting Ozempic from your doctor for a specific medical like a medical condition? Like are they made the same?
The compoundings are made differently, and I don't know enough about them to speak intelligently. What I can say is that the compounds have not been studied in pregnancy and breastfeeding. So when we're talking about the data, we're talking about the GLP-1 injectables or the pills that come directly from the respective manufacturers. So compounding may not be an issue in pregnancy. We just don't know because that's not the data that we have.
Okay. And I know Ozempic is used for diabetes. And so like my mother, she got her diabetes from being pregnant. She had gestational
Mhm,
diabetes 3 times, and the fourth time it just stayed.
mhm.
Um, I'm assuming that if they were to tell them not to do Ozempic anymore, there are other medications that are safe for pregnancy that deal with diabetes.
Yes, absolutely. So in that one case, we had them on the GLP-1 and also on metformin. So metformin has absolutely been used throughout pregnancy. Insulin is what we call the gold standard, meaning it works the best for the most amount of people. That doesn't mean that everybody will be on insulin, right? So I've had gestational diabetes. The first time they tried to control it with diet and lifestyle, it didn't work. So they moved me up to insulin. But yes, there are glucose control medications that have been approved for use in pregnancy and have been very well studied, right? Metformin is a great example. With that being said, if I was taking metformin and insulin and it wasn't doing the job that the GLP-1 could do, you have to have that risk benefit of, okay, like, is her glucose in control enough that we can keep her on these meds, or do we need to switch? So, right, that's what it really comes down to. There are other options, but the GLP-1 might have been a better option before pregnancy. So they have to take all that into account.
Okay. I just know it's like a really huge fad right now, and like my current boss got on it. I think like when semaglutide like first came out,
Mhm.
and I know that like the different, I guess, versions of it, they've like worked out different kinks in it. And so is there anything different, which I don't understand how like ordering medication works, but like the original semaglutide, is that even available anymore? Or you when you purchase it or you receive it, it's like the newest version of it. I don't know if that question makes sense.
It does. If they were going to greatly change a medication, they usually need to make modifications known to folks. I don't know if it's exactly the same as when it first come out, but it has to be very, very close, right? Or else all of that original data that they use to get the new drug application, which is part of the process of how the FDA regulates these medications, they would have to make big amendments to that. So my guess is it's the same or similar, but again, I don't know enough about it to give you a solid yes or no answer.
Okay. Um, Linda, did you have any questions while we're all just chilling?
I was just gonna say that it seems to me like the risk or the concern with semaglutide with a breastfeeding mother would be the calorie deficit that she might be having. And so even if the doctor, approves it, we're gonna refer back to the doctor always, as scope of practice. But it seems like we would also want to just suggest that they get with an IBCLC or, someone that is going to oversee the actual nutrition aspect and
Mhm.
make sure they're getting the nutrition that they need.
Absolutely. And again, as Jessica and I were talking before, nutrition counseling with the prescription of GLP-1s and other meds doesn't always go hand in hand. So it's a great reminder because that is the concern, right? The concern is that the person who's taking the medicine is not going to eat enough food to sustain themselves, never mind what they have going on if they're in the breastfeeding space as well. So yes, it is all about that client support, big client and little client. But yeah, that's going to end up being the doctor's call. But that is the concern, right? Because there are so many reports of people saying, I was hoping I would eat less, but now like I'm forgetting to eat altogether. Like it's not on my mind because it diminishes what they call food noise, which is why if if any of you have clients at any point in the addiction space, just know that they are looking to start treating addiction with GLP-1. We saw this coming down the pipeline because of what it does on the psychological basis. But yeah, that nutrition support is going to be number one for a mom and baby. Great point.
I was sharing with Chris before we started that I took semaglutide right when it was first coming out because I struggle, like food noise is a really big issue for me because I had a binge eating disorder for like most of my life. And it's a disorder that also just doesn't go away even when you've had weight loss surgery and you lose a lot of weight. But I was sharing with her that like it got to the point where my partner was like, I need to tell you something, but I need to tell you it in like a loving way, but like you look ill. Like you look bone, like you look like you don't have any sort of like new sustenance in your body because of how skinny I had gotten. And then obviously I was like, I'm skinny. Um, but that was something that I noticed in myself. So I can't imagine like a breastfeeding mom taking it for specifically for a weight loss, what that would do to her and the baby. Because there were times where I would stand up and get dizzy or feel passy outy because I hadn't eaten.
Yep. Or dehydrated, like if you end up, having a little bit more GI issue than what you thought. I know vomiting is possible. It's pretty rare. Diarrhea is not quite as rare. And we know then that's an easy place to sort of go. And it's, Jessica, you were saying about, people taking it to lose weight in the breastfeeding space. And not only do we know that that's a thing, but when I was mentioning a little bit about like TikTok and stuff like that, I mean, that is the expectation. You know, it doesn't mean it's realistic or a healthy expectation, but there is the, oh, well, you're breastfeeding now, so now's the time to get all the baby weight off and things like that. And so even when there are health concerns involved, sometimes the peer pressure is a little bit more. So encouraging that gentle reminder of, you still need to eat, you deserve to eat, you deserve to be nourished, your baby deserves to be nourished, and it can't just come from one source. So thank you for being that supportive voice because, like you said, food noise is real, but so is the desire to be thin. So there's a lot of competing factors out there.
I also know that it's really important to protect muscle during taking any GLP-1, and I think that gets missed. Hydration and muscle protection get very much missed from my own research. So,
Yep. 1,000%. Absolutely right. And again, it's not because folks aren't eating, it's that you are losing rapidly because the intake does not match what it once was, especially for folks who were bigger at any point for any reason, pregnancy or otherwise. So, very, very good points.
Awesome. Does anyone
thank
have
you so much.
what'd you say?
I said, thank you so much. This has been great.
Yeah, thank you. This was the one I was looking forward to the most just because of how hot a topic, especially the GLP-1s are. And I hear many times, well, my baby's good because I've taken the COVID vaccination. And so like actually knowing more about it. Um, well, Chris, thank you so much. I don't want to take up any more of your time. This was absolutely fantastic. And I will definitely be sending you an email, thanking you and thanking Mother to Baby for everything that they have done so far for us.
That's awesome. It was my absolute pleasure to get acquainted with the organization and be here today. And please remember, um, any questions, right? We've heard it all before, so please feel free to utilize our service. We're free, your patients too, but again, your clients as well. We're all in the same goal. So thank you for being out there and supporting women and families. Um, we couldn't do it without you, and I'm very glad that we don't have to. So thanks, everybody.
Thank you so much. Have a great rest of your day.
Take care. You too.
That was so good. I'm so in love with them.